I'm excited to be here and back to Cayman, and I love to be surrounded here by people who share the same passion. And what I'd like to do this evening is talk a wee bit about women's heart health.
So they say it's a man's world? Well, I don't see anybody's name on it. While they were out doing their thing, we slowly changed all that. We changed all that. Today, women can do anything men can do. And there's one thing we're even better at.
That's kind of a sobering message there, isn't it? Well, I'd like to, just at the first of the presentation, is give a wee bit of history. All of us here know the traditional risk factors and talk just a bit about heart attack and stroke, but really evolve into some newer challenges that we're facing with women's heart health. And I love some of these slides. In the 1980s, with our American Heart Association, these were the billboards that were on display. Learn CPR, save your husband's life. If your husband had a heart attack in bed tonight, would you know what to do? In the 1980s, really not that long ago, it was felt that heart disease was primarily for men, not being recognized that the impact it had on women. And then a lovely lady, you may see her back, oh, she took her hat off. My partner in crime, Marcia McCoy, in 1994, recognized some pretty sobering statistics that more women were actually dying every year from heart attack and stroke than men. In a little corner in her office, she began screening as a retail service and educating women about their risk for heart disease. And I love this slide in that it displays in the Kansas City newspaper. It says, guess who's more likely to die from a heart attack? And this to me is a landmark time in that she was truly a pioneer. And as we can see, it was 10 years later that really the whole national awareness, the Heart Truth campaign, kicking off the red dress, challenging people to be proactive about their health and recognizing that this was the #1 killer of women. So we've come quite a ways from the 1980s and those billboards, and recognizing Marcia's insight 10 years prior to this campaign of awareness. Well, one thing to stress is many feel that the heart disease is that for old women. We know it's the leading cause of death in women over the age of 35. And the earlier we think about it at a very young age, the better the impact we will have on reducing the statistic. We've budged the statistic just a bit. In 2003 at presentations, I'd say, look to your left to women, look to your right. It's you or the woman next to you who is going to die at some point in their lifetime from heart attack or stroke. Well, we bumped that up to a sobering 1 in 3, whereas 1 in 30 will die from breast cancer. And the awareness, the strategies, the therapies for breast cancer, now more and more women are living with breast cancer than dying from it. And that heart disease kills more women than all forms of cancer combined. And it is a silent epidemic yet. We still aren't where we should be. And look at some of these statistics that the first heart attack in women is more likely to be fatal than that in men. And with congestive heart failure, we're all feeling the impact of heart failure, no matter where we live. In women who have heart attacks, they're more likely to develop complications of congestive heart failure just within 6 years after their MI. And those who've had a stroke under the age of 65 die within 8 years. And unfortunately, we can't count on symptoms because a lot of women are dying without any prior or recognizing the warning symptoms. And so now here's some of the newer campaigns, how they've changed from the 1980s. The signs were there, but she ignored them. So some of our challenges still are very, very simple, but they're real. We've raised the awareness, but still not enough women are aware that this is their #1 health threat. They don't recognize the symptoms. They delay seeking medical attention. In the setting of a heart attack, women will show up to the emergency department 4 hours later than men. And as we know, time is muscle. And they're more likely to have other problems or comorbidities that increase their risk of cardiovascular disease. And in comparison to men, women are far less likely to have their risk factors controlled. And so awareness has increased, but yet the proactive action, the change has not. And I'm really excited about the health fair tomorrow because I think the more we repeat the message, hopefully we can be successful in engaging people to take action. And as the red dress is the national symbol for raising awareness about heart disease in women, much like the pink ribbon for breast cancer, because we are fashion-minded. We think more about our hair, our nails, what we're going to wear, because it's important, our visual. So I always feel that if our hearts were visible, we would certainly take better care of them. And a term I've used called the Bermuda Triangle, we've impacted mortality. Women dying from heart attack and stroke, we have made a difference in the past 10 years, except one age group. These are women 35 to 45 years of age. And the Bermuda Triangle is that these women are overweight, they smoke, and they're on birth control. And we know that's high risk of thromboembolic events, strokes, heart attacks. And so we continue to evolve in our awareness and to here emphasize this is not a disease for old women. And I think we need our generations to recognize this. And as this nice young lady here with an awful sternotomy scar, if heart disease is a man's problem, why are more women dying from it? We're aware of the traditional risk factors. Unfortunately, more women continue to smoke than men. And why is that? Why can't we get women to stop smoking? They don't want to gain weight. That's that visual again. They know you can't see the heart attack, but they know you can see that they've gained weight. And we know, gosh, our poor patients, I don't know about here, they're so confused. We keep changing the guidelines. Where do we want blood pressure? Where do we want their cholesterol? Where do we want glucose? Do you take an aspirin? So I think we have a duty on our behalf to try to solidify, clarify, simplify where we want these numbers to be. And then certainly waist circumference in our country is not unique to others. Our bellies are what I call warehouses for foods we don't know what to do with. And especially that postmenopausal woman with various reasons of that midline gain markedly increases the risk. And we'll touch more, I want to spend the majority of the time on the hormonal changes that we think are influencing the other unique gender aspects of cardiovascular disease that we really don't know how to successfully treat. Menopause is a critical time, changing time, and whereas women now make up the majority of the population, the majority of women now are postmenopausal. And menopause, we know, is a risk factor all women share, and we can see how the cholesterol changes, just mere cholesterol changes around menopausal state, where we blow right past men, proudly do so after age 50. An area I'm really passionate about, and I would love to ask that every home in every country has a blood pressure cuff, or at least pinpoint where one will go and have their blood pressure checked. If we're asking people to check breasts, for men to do testicular check, for diabetics to check their glucose at home, why aren't we asking our patients to check their blood pressure at least once a month at home? And because it is recognized as the most neglected disease. And it's truly the single most important risk factor, accounting for blindness, stroke, heart attack, atrial fibrillation, 2 types of heart failure, kidney failure, need for dialysis, and erectile dysfunction. In America, this accounts alone just for 1,000 deaths a day. And what I've really respected talking with businesses and the employers, that just high blood pressure accounts or is in the top 5 for employers' expenses. And so we have a lot of business interest in controlling blood pressure. And women are much more likely to walk out that door with their prescription in hand and not fill their prescription, much more than men. Or if they fill it, they don't refill it. In respect to gender and ethnic cultures, we know that hypertension has a higher mortality in African Americans, and especially women with poorly controlled blood pressure. They are at much greater risk of cardiovascular disease than men. Again, a common cause of erectile dysfunction. And even if we have hypertension, and especially been shown recently in women, controlling blood pressure negates that risk of cardiovascular disease, puts them at that equal level of one without hypertension. Here's what we're thinking now in respect to guidelines, keeping blood pressure under 140/90, but over 80 with the American Heart Association now raising that seated systolic pressure. Who knows what we'll say next year? I guess we're all staying tuned. And we talk in my discussion with my patients, and especially with women who feel they're too busy to do everything, they don't have time to go get their blood pressure checked, challenge them to commit to having a blood pressure cuff at their home. And I think what's very, very important is the lifestyles that we have and how women reward themselves for the busy days they have. We are comfort eaters, and so the comfort foods are the inflammatory foods. They put weight around our waistline, they crank up our blood pressure, our triglycerides, and just break our body down. And truly though, nothing tastes as good as health feels. And today, earlier talking with the team, we thought if we just would eat what our body needs, not what we want, our plates would look a lot different, and our blood pressure would be a lot lower. We've emphasized, I know, in a lot of the discussions about the importance of movement. What I really challenge people is to check their blood pressure before they exercise and then after, and it comes crashing down. It's very rewarding for people to exercise. And we're aware of other causes, the sleep apnea, and then use of various medications and supplements. Smoking, still, as we said, in women, much more prevalent, a big trigger for hypertension. And then what's so important is and not to disregard, is the impact of birth control pills on hypertension, and especially now with the American College of OBGYN saying, you know, women could stay on hormone therapy throughout their lifetime, just transition from premenopausal birth control to postmenopausal hormone replacement, provided they have their risk factors under control. Well, who's controlling their risk factors? They're just wanting their hormones replaced. And so we've got to make sure that if one is writing a prescription for any type of hormonal therapy in women, that they should keep bringing a diary and trade that prescription for a diary showing good blood pressure control. In the more recent guidelines for prevention of heart disease in women, they've recognized the importance of, if there was pregnancy and hypertension, that these women are a much greater risk of hypertension later in life. It's kind of like they just flunked their stress test during pregnancy. And then no one here is stressed. If you're on the Cayman Islands, right, and just here for a lovely meeting, I mean, gosh, isn't this great? A meeting, sipping on a glass of wine, and so we can't be stressed. But I don't think we understand or respect the impact of stress. I think it's hard to measure, to do statistics on and report. But we know that this is a big factor, and especially in women who are in the same position as men in the workforce. With the stress, if the differentiating factor or with stress, it has a much higher toll on their cardiovascular health. So I'm thinking as women, we probably need a siesta, right, in the afternoon sometime. And I don't know, Rob, you can come along and nap with us too then. And we know about the medications. I won't go into that because I want to spend much more time on the hormonal aspect. So if we're not convinced yet of the importance of controlling blood pressure, we know that this markedly increases atrial fibrillation. And this is epidemic AFib, especially in women, especially postmenopausal women. And they carry a much higher risk of complications. And with hypertension, just that poor myocardium trying to eject blood against hypertension, we know that causes hypertrophy, diastolic dysfunction, and what's epidemic now is diastolic heart failure. And which in our country, it's the #1 reason for admission to the hospital. And then complicate uncontrolled blood pressure with the stiff heart, the need for diuretics, and we get into that awful cardiorenal syndrome. And of course, the metabolic syndrome, the combination of risk factors, which now accounts itself for 4 out of every $10 spent on prescription medications, and largely preventable. And we're very familiar, and what helps patients understand about heart attack and stroke, it's not the plaque, but the crack that triggers the crisis, and it's all about inflammation. And patients really get it when you talk to them about their coronary artery disease, like acne, that they've got coronary artery acne, and you got to keep that pimple from popping. And things that pop that plaque, and those risk factors, traditional and non-traditional. We want to work closely with our subspecialists, the oncologists, the rheumatologists, immunologists, and especially women, more so than men, with immune system disorders such as lupus, rheumatoid arthritis, undefined immunologic disorders, that when they have a flare of their rheumatic or immunologic disease, we see them come in with spontaneous plaque rupture and comorbidities of myocardial infarction. So we want to make sure, especially in those with immune system disorders, women far more than men, that they understand the importance of controlling and treating that. And then some other simple things, the inflammation in gums and gingivitis, which in women, especially postmenopausal women, markedly increases. And still suspicion and discussion about correlation of oral hygiene and plaque in our vascular system. And I think one of the most fascinating areas right now in women is that, the way we practice medicine and treat everyone is primarily based on studies in white, middle-aged males. And now we're recognizing conditions in women that have not been studied, and there's a cry for research in this because I think we would manage these disorders a lot differently. What we didn't recognize is that there's estrogen in our blood vessels, or estrogen receptors in our blood vessels and in our myocardium. And when estrogen finds that receptor, it releases nitric oxide. And wow, if we could just all supplement with nitric oxide, that's just like the fountain of youth. It dilates our blood vessels, it relaxes our myocardium, it preserves that diastolic function of the heart. And when we go through menopause and we lose the estrogen, those estrogen receptors atrophy. Nitric oxide falls, and then aldosterone goes up. And we know what aldosterone does. It constricts our blood vessels, it stiffens our heart muscle. And within that, there's a relationship then to the diastolic dysfunction, diastolic heart failure, which we'll touch base on. And it's been looked at, this theory, some in human women, but right now the best friend we've got are rats who've had oophorectomies. And then they put them on the treadmill to do ultrasounds of their heart with and without estrogen, and have supported this theory that the menopausal state, loss of estrogen, loss of nitric oxide, increased aldosterone, is triggering a lot of this storm we're seeing in women that really compromises their quality of life. One of my mentors at Mayo, Amir Lerman, is very dedicated to studying the impact of nitric oxide on our vasculature, has done intracoronary studies, a believer that L-arginine, the precursor of nitric oxide, is going to help us understand that. And there's some studies going on with oral L-arginine over-the-counter enhancing, which is the precursor to nitric oxide, looking at diastolic function. But we've got a long ways to go. I'm sure all of you here have been seen or have seen someone or personally experienced, I call them the skips, flips, and flutters. And probably the most common reason I see healthy women in the office, they're at rest and then they start feeling these skips, flips, pauses when they're at rest or lying down. And when they get up and take off and exercise, they go away. Very interesting, these PVCs, PACs, are far more common in women than men. Some women, the week prior to their menses, these will come out like crazy. And a lot of times it's just reassurance. These can be very frightening, reassurance that most often they're benign. But I have a number of women say, I don't care how benign they are, make them go away. And that's then depending on if they're open to certain medications, or even some have a lot of PVCs and a significant PVC burden, where we can link that to the development of a cardiomyopathy. They've gone on for ablation. And then if this microvascular angina is also very interesting, where we know the epicardial arteries can be normal, but the smaller arteries into the myocardium, if they've got a stiff pump, just with hypertension, can trigger classic angina. And there's been studies documenting, women classic angina, bump their enzymes a bit, come to the cath lab, and their coronary arteries are normal, their echocardiogram's normal, but they're hypertensive. And so if we treat the blood pressure, then that microvascular angina, if they exercise, treat their risk factors, that does get better. We want to educate women with polycystic ovary syndrome. We know these women by the midline obesity, the male balding pattern, high triglycerides, the metabolic syndrome, because they are at higher risk of premature coronary artery disease. I think it's interesting, the spironolactone, the renewed excitement about spironolactone in this population, those with aldosterone predominance or the androgen predominance. You guys doing all right? Anyone need another glass of wine, or just start passing the bottles around, or teas? Okay. And so in pregnancy, I have some of my colleagues have staffed the heart disease and pregnancy clinic. And we know in pregnancy, very commonly we see palpitations, and whereas predominantly we feel those are normal, it's certainly well recognized. We had a woman where she came in with rapid AFib that we had to, she was pregnant, put her in the unit, she was decompensating and cardiovert her. Another woman, it was right ventricular outflow tract ventricular tachycardia she was having, who required an ablation. And so where we think that they're very common and likely benign, it just warrants checking out further. And in women with gestational diabetes, just like the hypertension, we know these women have flunked their stress test. They need to be followed much more closely. I'm really excited about the Gooches. And the Gooches, we are called the grown-up congenital hearts. These are women who would not have survived their congenital heart disease, but due to successful surgeries when they were infants, now we're seeing women as adults who want to become pregnant. And what are their risks? And what is important to understand is what was their defect, what were their surgeries, do they have a stenotic valve versus a regurgitant valve? We know the stenotic valves in pregnant women are much riskier, have a higher risk pregnancy than the regurgitant. And what's the risk to the mother, certainly of pregnancy? What's the risk to her baby of also having congenital defects? Here, her father's eyes, her mother's heart disease. And I think that with these collaborative efforts with our OBGYNs, that it's a much more efficient trip for these women, and we have the whole team coming up with a plan. And Marcia, how many did we deliver in the ICU last year? I can't remember. So we had at least 5 women. You think it's a lovely experience, childbirth, or it's warm and fuzzy environment, but we had a number of women that we delivered in our CV ICU with our cardiac anesthesia team, and got them through it. This is a lovely lady, Catherine Marshall. She had twins, and after her twins went into fulminant heart failure, renal failure, and fortunately she's done well. She had peripartum cardiomyopathy. When I was in training, about 50% of women would die from postpartum cardiomyopathy. Now I'm not seeing that. I mean, I don't know if it's earlier suspicion, now being able to take the medications, cardiomyopathy medications, and breastfeed, provided the baby's normal weight. And we feel that it's multiple pregnancies, those with high blood pressure, autoimmune, and if they recover their LV function within the first 6 months of delivery, we think these women carry the best prognosis. Some will do a stress echo on to see what their contractile reserve is with stress. Does it go up or does it stay flat if they recover their LV function? If they recover well within 6 months, and then they have good contractile reserve with their stress echo, that might be a population that we consider for second or other pregnancies, but they'd need to be closely followed. Spontaneous coronary artery dissection is being respected more and more, and I think this is a tribute to the women in the country, our country, who have gotten together to form this SCAD foundation. It's a hormonal-related spontaneous tear in the coronary artery, and it can be devastating. We had a young girl who a year ago on Mother's Day had sudden death and the spontaneous tear 6 weeks after delivering a baby, that fortunately through our hypothermia program and such she survived, but not without a very long complicated course. So why are these young women, hormonal related, spontaneously having dissections in their coronary arteries? We're trying to find, how do we detect this or prevent this or identify, and is there a better way to treat? You know, we prefer not to stent if we don't have to. We know that that'll tack itself back against the wall. But hats off to that group of women who they know they're rare in their own community, but together with this foundation, we've garnered a nice database of blood work that we're trying to sort through. Stress cardiomyopathy, interestingly, appears to be much more prevalent in women. The Takotsubo cardiomyopathy, the woman comes in, classic heart attack symptoms, enzymes are bumped, EKG's not normal, take them to the cath lab, and their coronary arteries are fine. But their left ventricle on the left ventriculogram or echocardiogram looks like a clay pot, where the base is hypercontractile, the rest is ballooned out, which is the Takotsubo term. Fortunately, most of these women recover pretty quickly, but it's awesome to watch their EKGs. They get deep T-wave inversion, and then they go back upward. But far more prevalent in women, much, much more than men. We've heard about the chemotherapy, the radiation therapies, and the impact on women's heart health, especially women who may have had Hodgkin's disease years and years and years ago, where we couldn't tailor the radiation. And now, much later in life, we're seeing restrictive cardiomyopathies, coronary disease, valvular disease. We encourage women, if they have a history of cancer, to know what chemo agents they used for their breast cancer. Was it adriamycin, Herceptin, chest radiation? Did they have it or not? Because I think it's important for them to understand, and then we work closely with our oncologists as well. As we said, with the estrogen receptors and then the atrophy in women, you look at if you look at an echocardiogram and it says hypercontractile ejection fraction greater than 75%, mild diastolic dysfunction, you can just predict that's on a woman who's gone through menopause. And so with menopause, we get this stiff pump. We have skipped heartbeats, our risk factors change, and sleep disorders, I call it monkey mind. We can go to bed, but we wake up at 3 in the morning and we are just problem solving. We release cortisol, that puts down the belly fat, and then sends all the rest of our risk factors awry. With hormone therapy, from a cardiac standpoint, still we're going by the indications for menopausal symptoms. So as long as that woman doesn't smoke, or have a clotting disorder, and blood pressure is controlled, we say don't stop hormones for heart reasons, don't start them for heart reasons, but do for menopausal symptoms. So with this diastolic dysfunction, and this is so prevalent now in postmenopausal women because our pump gets stiff, and this is especially so in those with uncontrolled hypertension and diabetes. The BNP can be elevated in these women. They don't necessarily have heart failure, but increasing myocardial wall stress will increase the B natriuretic peptide. This is the woman who says, I can do anything, but trying to run up steps, I am so short of breath. Or doing anything with my arms, carrying my grandkids, I get so short of breath. you can just bet there's a component of diastolic dysfunction in these women. With that, stiff pump stretches the atria. So you see it on echoes all the time in postmenopausal women, dilated atria. What a great substrate to house atrial fibrillation. And the older women get, when they go into atrial fibrillation, their heart rate response is more likely to match their age. So they're less likely to know they're in it, which then we know what that means, the risk of stroke. And it's an observation. It's shown in studies, of course, with our cohort, the rats who've had oophorectomies on their little hamster or rat wheel. But in women, if we just back it all the way up, if they would just merely stay active, exercise, control their blood pressure, we've seen that that helps preserve diastolic function. And the type of exercise these women need to do is not the warm up, maintain, and cool down. It's interval training. Because when they start off exercising, they've got to warm up. They go 0 to 60, they're going to get short of breath with that stiff heart. And then push till they can't say a full sentence without taking a breath. Back off. Just slow down, recover, push back into it, recover. What they find over time is they can push longer and back off shorter. So the interval training in postmenopausal women is far more, gives them more success. And so with that, if understanding that all this with the estrogen receptors, aldosterone, should we be thinking of ACE inhibitors, angiotensin receptor blockers, spironolactone, hydralazine as a first-line therapy for hypertension in postmenopausal women? And it seems to fall out in theory. And with, as I mentioned, the atrial fibrillation is an epidemic now in postmenopausal women. We're deconditioned, obese, hypertensive, with diabetes and sleep apnea. Isn't that the perfect storm for atrial fibrillation? And the CHF score we know we use to determine the need or the indication for anticoagulation, which women are much more likely to take. And we know that women with atrial fibrillation are far greater risk than at stroke, for stroke than men. With the guidelines for heart failure, which we know is just epidemic, it's saying prevent heart failure, treat it, but know when to say when. And that's where I know we're suffering a lot as providers. We're used to treat, and then we know we can't treat anymore. We kind of abort our patients, but that palliative care component of heart failure is so, so important. And in respect to heart failure in women, there's a lot of us with heart failure. We develop heart failure later than men, and we live longer. We account for more admissions for heart failure and require hospitalization more than men. And we're more likely to have depression if we have congestive heart failure. As we noted, a lot of women will develop heart failure within 6 years after their MI, and we know the different causes of congestive heart failure. Hypertension, in addition to coronary disease, ranking right up there. And in women with that metabolic syndrome, just more risk factors, comorbidities, they're much more likely at risk for developing heart failure. And in recent studies, up to close to 50% of heart failure patients have a history of diabetes, which is a rate that's nearly doubled in the past 10 years. And with the studies on heart failure, they've been predominantly on men with weak hearts, where most of the admissions now for heart failure are women with stiff hearts. We have one study that was neutral, the CHARM study, looking at ACE inhibitors, angiotensin receptor blockers, and it was kind of a neutral finding. So we're kind of winging it when we come to treating diastolic heart failure. But again, these women require blood pressure control, often a diuretic, and then it gets into that cardiorenal syndrome. And it's that love-hate relationship we have with the cardiologist, the nephrologist. These women get short of breath, they start to swell, we put them on oral diuretics, and then they have the abdominal distension, they don't absorb their oral, so they come in for IV. Then the creatinine goes up, the kidney docs say, well, stop the diuretic. Then the creatinine gets happy, then the volume goes up. Then it's on to dialysis, and it's this downward spiral that is eating up healthcare dollars, compromising quality of life, and making all of us stay up really late and work really, really hard, when if women would just back it all the way up and take ownership of their heart and merely control their blood pressure, stay active, and maintain ideal body weight, this would be a win-win for everyone. But again, there's lack of clinical and gender-related trials here. And this is just showing women with preserved systolic function having more heart failure than men. We already touched base on that. And I encourage women, if they have the opportunity to participate in research, even if it's a survey, encourage them to do so, because right now we're still not having the number of women in research trials that we really need to be. There's the Heart for Women Act that got signed by President Obama in America that said if we fund research that applies to heart disease in women, you can't fund it unless it includes women and to the number of women that you can do statistics on. And here's some of the representation of women in heart failure trials, with women on the right compared to men. And there's various reasons. Try to line up a number of women who are the same menopausal status, hormonal status, and it can be quite challenging. And then the ICD trials, device therapy. Even some of the devices, the older HeartMate to the newer one, Marcia and I did a FaceTime back to our Women's Heart Center. We had a congresswoman who visited one of our recent female transplants, petite little thing who waited as a 1A in our ICU for weeks with a subclavian balloon pump. But this balloon pump kept kinking because it was too big for her and there wasn't a smaller size. And so we've really been challenging our congressmen, congresswomen, representatives to really encourage device companies to make sure we include women, because just like Jenna, there was not another smaller balloon pump anywhere in our area. When one arrived, she had to have the other one pulled out, so she lowered her transplant status. She could have died in those 4 days, because when the other smaller, little, tiny one arrived, it had expired. And so we had to go and find another one where the company said, well, we just don't make many of those. And so that's not unique, these little petite women needing defibrillators and LVADs. And so we're encouraging our patients to be advocates for this as well. And then lastly, the AHEF trial. I love this trial, the African American Heart Failure Trial, which looked at nitric oxide enhancing medication. So it was a fixed dose of isosorbide and hydralazine, and looked to see did it improve outcomes in African Americans with moderate to severe heart failure. And it's interesting, we do feel there's a difference in response to ACE inhibitors in African Americans versus non-African Americans. And I think that baseline theory complements this trial. But I love it had the largest percentage of women as well as the largest number of African American women in a heart failure randomized trial. And it was the first trial that really looked at the efficacy of this in women. So looking at this, the study was terminated early because it showed early evidence of increasing survival by adding isosorbide and hydralazine to already the good regimen, the ACE inhibitor, the beta blocker. But often we need something more for blood pressure control. The hydralazine isosorbide is a great additive. And so in this population, it reduced hospitalization, improved quality of life. And then look at the survival curves by gender and treatment. And we can see that in women had a much better or effective response than men with equal types of heart failure. But I love this slide. If we go back to that hypothesis of women losing nitric oxide when the estrogen receptors atrophy and then the aldosterone goes up, looking at the percent reduction in mortality from everyone to men, let's see if I can point here, there we go, to women. And women versus men had much better response, much more reduction in mortality, especially that woman who was over 50 years of age. So that postmenopausal woman, when we enhanced nitric oxide with hydralazine and isosorbide, which we know that's part of their mechanism, that group had the best benefit on survival. And so in summary, we know heart failure, it's the most common diagnosis for admission in our population. Women account for more discharges, with diastolic more common. Therapies to treat heart failures, predominantly based on men with systolic, we clearly need more research and to, again, with the guidelines, prevent, treat, and advocate. And then backing it all the way up, it just continue to encourage our women to take ownership of their traditional risk factors. We've got to find a way to get these women to stop smoking, controlling blood pressure, merely knowing cholesterol, diabetes. I mean, having wonderful health fairs like tomorrow, I mean, it's such a benefit to the community. And then be aware of the non-traditional risk factors, partnering with OBGYNs, oncologists, immunologists, the rheumatologists, for these other more unique gender-related cardiovascular issues in women. And if we look at, today we're talking at the 6 bullets in our Nurses' Health Study. 80,000 women have stayed together for, over 20 years, allow every bit of data to be collected on them. And they just released 6 bullets that reduced risk of heart attack in these women by 95%. It was eat healthy, foods without nutrition labels, eat what your body needs, not what you want, stay active, ideal body weight, don't smoke, limit alcohol, and stay and avoid prolonged sitting. We think sitting now is a new smoking, so we shouldn't be sitting more than 30 minutes at a time. Uh-oh, does that mean we got to get up and stand right now? And so just taking ownership of that, women can reduce their risk of heart attack and stroke, much like men, but we're less likely to do it. It boils down to one word, and that's discipline. So none of that requires them visiting us or having a prescription. It just requires hard work. And we'd like to recognize the Heart Health Center as the first non-U.S. site for promotion of the National Heart, Lung, and Blood Institute's Heart Truth campaign, and certainly proud to partner with our colleagues here. It's been a wonderful collaboration. And this was the Heart and Soul in 2011 here with a lot of the red dresses on display. And this one, I think, was designed by a lady here in Grand Cayman. And as a reminder, look at these beautiful young women. As a reminder that heart disease is not for old women. These women have met through one common ground. They've all had a heart transplant. And so it's the face of heart disease in women, I think, looks a lot different than how we feel for it to be. And so this was snow on the ground at the Heart Institute, unlike what we have here. But I heard it was snowing a wee bit there today, so I was rubbing it in, the beautiful weather you have here. But thank you for allowing me to blether on about women and heart disease and encourage women to get involved in research and surveys and encourage them to take ownership of their health. It works if they do that. So, thank you.
Thank you, Dr. Stevens. I'd like to invite any questions from the audience at this time.
Tracy, my question for you is on diastolic dysfunction. If I have a patient with a large anterior wall MI, I have no trouble getting that patient into cardiac rehab. We have great studies that show that there's benefit from cardiac rehab. Back in my heart failure days, I struggled to get patients with systolic heart failure approved, and most of the time we lost money, even though plenty of studies show benefit in systolic heart failure with cardiac rehab. Is diastolic heart failure the new frontier? Should we as practitioners be advocating for the insurance companies, and especially in places like Cayman, where we don't have so much of the red tape, should we go to our insurance companies for these postmenopausal women who suffer from diastolic dysfunction and say, we need exercise programs? This is the future of treating this condition. Can you comment on that, please?
Oh, I think, Rob, you're right on track. That would be phenomenal if we could get that covered. It still requires that woman shows up for cardiac rehab, which we know women are far less likely to show for cardiac rehab. And to know that it would be covered by their insurance plan and document, wouldn't it be great if you could get a grant that before they start, you look at an echo and their diastolic function, and then pre and then post exercise, because it's more in our echo lab we observe that, but really to get a scientific good trial to really document it. But I think you'd be right on track with that, because it's clearly reconditioning that heart that's just gotten so stiff, and we've seen it, especially with that interval training, that it really improves their diastolic function. And gosh, just think of the impact you'd have with reducing hospitalizations and dialysis and strokes from the AFib that comes with it. Thank you.
Any other questions? Nope. Thank you very much, Dr. Stevens.